2021 virtual big chat and AGM meeting. If you've just joined us, just a few little bits of housekeeping. I'm Dr. Pete Chamberlain, and I'm the chair of South Sefton CCG. Just going to go through a little bit about what's going to be happening tonight. So first of all, if you can stay on mute, there is going to be opportunity for interactions, but stay on mute and turn your cameras off while the presentation is taking place, just to ensure basically the bandwidth. Okay. Oh, we've got a little bit of interaction already. So we are recording today's event, and it will be able to be viewed later from our website. If you are struggling to find the mute button, our comms team will mute you on your behalf. All right. If you've got questions, then there'll be plenty of opportunity to interact. But we'd just like to ask you to let each presenter finish before basically putting your hand up or putting a question in the chat function, and we'll be able to get back to you either within the presentation, or if we don't answer your question today, we will answer it definitely afterwards. Now we've got a few people helping today. So Jonathan is helping with a poll. There's going to be a few opportunities for you to share your opinion, and Jamie's monitoring the chat. I won't be able to see the chat, but he'll be monitoring the chat and be happy to kind of pitch in if there's something helpful to say. So yeah, without further ado, we will move on. There is a few other key aspects in relation to emails and things like that to our communications team, should you want it. And if we can move the slides on to what we're going to cover tonight, then we will be able to hopefully go through the agenda. So Fiona, our Chief Officer, will be covering the previous year, which is obviously, as you appreciate, being a big one in many ways, and a look at some of the successes actually despite the challenges. We're going to be looking at our performance. That's from an NHS perspective, and Martin's going to be covering some of the finance as well. Where does the money go? Then back to Fiona, looking at where we're at now, but what's actually happening in South Sefton in the next few months, coming up into next year, 2022, the developments that are afoot in the NHS, and to update everybody about that. We're then going to think and take a bit of a deep dive into the future of health and care in Sefton, and we've got Eleanor from the council. And it's been a very topical few months for general practice in many ways, and so we'll be doing a bit of a deep dive on what actually happens in a general practice on an average day, and what's the state of general practice from a national and local perspective. There'll be opportunities for you to share your experiences through breakout rooms with our facilitators. So to kick off today, we're going to start with our first poll question, which is basically just to get you warmed up. And how did you hear about today's big chat? So the poll effectively is going to pop up, and if you could just vote as per your invitation, that would be fantastic. And there are quite a few CCG colleagues on tonight, which, you know, we're happy to take into account, but it's understanding where the opportunities are. So a lot of people invite from the CCG directly, but quite a few people, not insignificant, through social media. Obviously, new ways of communicating. So thank you for that. So with no further ado, we'll hand over to Fiona, who will go through our last year and some of the successes despite the incredible challenges.
Thank you, Chair. It's lovely to see so many of our colleagues who usually join us on these occasions, and it's still unusual circumstances to not physically be having a conversation with you, but hopefully the way that the team have set this evening up gives you the opportunity to interact with us. But lovely to see you. I didn't imagine 12 months ago, when we'd been in lockdown for about 6 months, that we would be still in this position 12 months later. And it has been an unusual year, and I want to put on record my thanks to you as our public, my thanks to the staff in the CCGs, in the clinical commissioning groups, and my thanks to all those who are public servants across the many different disciplines. It's been another year like no other, as Pete Chamberlain was saying, but what I want to share for a couple of slides are some of the things we have been able to achieve within the context of the COVID pandemic. Next slide, please. So I think together, and that's been with our public, we have responded to the challenge to keep our public and particularly vulnerable patients as safe as is possible, with circumstances that certainly my 40-year NHS experience has never seen the like of. I think we've worked incredibly well. We've got a vibrant voluntary community and faith sector. That's what the VCF acronym stands for, within Sefton. And only in the last 24 hours I've received a publication where we've been able to describe that, and my grateful thanks to the sector and Angela White at Sefton CBS. So working together, we actually put together a volunteer programme, and you can see in the bottom right hand corner 81,417, and that's the amount of, if you like, cost, if we were to translate that into salary, that volunteer time has donated into the vaccination programme in Sefton. And I think everybody should be incredibly proud. I was able to go out on the front line after some training, I would say, to vaccinate alongside colleagues, and the volunteers, the energy and the compassion to help with our clinics where we were seeing vulnerable patients was second to none. So thank you to everybody who's involved in that, and I think that was a great achievement for Team Sefton. We can see here the vaccination programme, which is still ongoing, the number of first doses and second doses for South Sefton from our resident population of 156, just over 156,000. Next slide, please. So apart from the pandemic, we have been building on some of our work. Many of you will have helped us a couple of years ago develop our 5-year plan, responding to the NHS plan. And we developed something called Sefton Together, and obviously the together is not coincidental. This is about working with yourself as a public and also with our partners, including the local authority Sefton Council. Some of you may be in the breakout session where Suzanne Lynch MBE is in that session, and obviously I think I said to Suzanne, it's all very hush-hush, and when I found out, when she contacted me when she was able to, just before it was published in the national press, it felt like I'd won about 500 MBEs. To know that a member of my staff was in that position, to be recognised for the work that they'd done at the front line in the COVID pandemic, makes it, me and all of the CCG colleagues and others, extremely proud. There was also a shortlisted nomination with within the Parliamentary Awards, which happened in this year. We retained our annual rating, which NHS England oversee that, and if you like, tell us where we are. And what was particularly pleasing was the retention of the highest level for public engagement, and I think it's one of the things why I'm really pleased that I can see some of you on here, that, you know, it's been limited this last year, but we pride ourselves in Sefton, in the CCG, working with the council and others, to really try to get into and understand your issues, concerns, and how things can be done. And when one of the last elements of achievements is the real work that we've done alongside the council within our care home sector in Sefton, and really trying to work very hard in an area that many of you will have seen in the media is a very vulnerable part of care in our society. And we came together with the sector to do the best that we could do to serve and make sure our population were as safe as they could be during the pandemic. Next slide, please. So how did we involve you in 2021? Well, in a way that we've not done before, which is through a virtual AGM, and we did that last year. As I say, I wasn't expecting 12 months later to still be in virtual mode. I'm not an avatar, I am still living and breathing, and you know, hopefully very soon we'll be back on the shop floor in Sefton. We've worked with our partners, as I said before, on some of the achievements that I've already described, to really understand, particularly around elements of our communities where people are a little bit more cautious and hesitant to get the COVID vaccine, and how can we help people to understand. So we've done that in partnership rather than it just being solely ourselves. We've got the whole piece of work up at the top end of our patch, which some of our patients in South Sefton, particularly if you live around the Maghull area, flow into Southport and Ormskirk. So, you know, we have been through an engagement process that will be ongoing. And also, we've been working hard to improve language services in general practice. So again, trying to get feedback and input from yourselves. Next slide, please. So COVID-19 is still a huge challenge, and as I sit here today, I would say whilst we've got vaccine coverage, there's still a way to go. We're still saying to everybody, you know, be mindful of hands, face and space, and I think those messages are still as important as ever. We still, Martin will talk to you a little bit in more detail around the finances of the last 12 months, but there are still financial challenges, although I think the news was announced about the additional funding coming to the NHS. There are pressures. We've particularly devoted a lot of the time today for a conversation around general practice. We're very aware of some of the recent media attention, and we need to address those issues within the resources and the workforce that we've got, and we're very keen to do that. And certainly, as I think I said when I opened up, the ability to engage with our public in the way that we would normally do has been very limited. But I have to say, as I always say to everybody, 24/7, 365 job, that is my role and others. So we are contactable, and if anybody should want any conversation, really, really happy to engage in that. I would like the next slide, but I believe I am going to move on to where we're going. We've been developing a shared vision, and that's the Health and Wellbeing Board strategy vision, so the council's strategy that's through the partnership that we have at the Health and Wellbeing Board. So a confident, connected borough that offers the things we all need to start, live and age well, and where everyone has a fair chance for a positive and healthy future. So rather than, you know, many visions a bit like Specsavers, we are focused on one shared vision now, and this is the shared vision across the partnership. Next slide. Helly will say a little bit more about that. Many partners, including yourselves as the public, if you are joining us, and our other colleagues across health and social care within the local Cheshire and Mersey patch. Next slide. And this is where I allow Martin to take you into much more detail about how we've been performing. Thank you.
Thank you, Fiona. So in terms of overview of our performance, from a financial perspective, we were allocated a budget of just over £312 million, and that equates to £1,996 for every South Sefton resident that we have. In terms of our performance throughout the year, we reported a break-even position for the 2021 financial year. This was an improvement from the significant deficit, £8.9 million that we reported in 19/20, but was delivered largely as a consequence of additional funding that was made available to support some of the COVID pressures that emerged during the year. The CCG's underlying position remains challenged, as Fiona alluded to, and we'll be doing some work to understand how the remainder of this financial year will be sort of resourced, and what that means for the CCG, and also an insight into 22-23 on the back of the announcements yesterday, to try and work out exactly where we can put our money to make sure that we get the best value for taxpayers. Moving that through, the external auditors also issued an unqualified opinion on our accounts in terms of both our regularity. So what that means is that the way we spent the money was in line as expected, and also in terms of our value for money. So we were able to demonstrate that the decisions we were making were sound and were in the best place for, as I said, the delivery of value for money for our taxpayers. Next slide, please. So this slide indicates how we spent our money across the varying elements. So acute services takes up the main elements of our budget, 47%. Then it's split into a number of different areas: community services at 11%, continuing care at 8%, mental health at 8%, and some of those two items will be interlinked. Primary care and prescribing, we spend 10% of our budgets on each of those. 4% supporting our programmes that we have in place across Sefton, including the transformation programme, and 1% on the CCG's core administration budget as well. So all in all, a relatively lean organisation in terms of expenditure on administration compared to the overall pie, which is £312 million, as I said previously. In terms of some of our performance, next slide, please. We are continually looking to improve our performance, and some of the areas of focus in what was a very difficult year. We were able to make good progress in the restoration of diagnostic access. So residents of South Sefton, 8.4% wait longer than 6 weeks, which compares with 24% at national level. We met some of our important mental health targets. So first episode of psychosis and the CPA follow-up. So that's after somebody has been someone has been discharged from an inpatient bed, to make sure that the follow-up takes place in an appropriate period. We met the national standards for those two areas. Our infection control targets were achieved in both MRSA and C. difficile, and also the 31-day cancer treatment target set at 96%. Pleased to say that within our residents, 96.7% of our residents commenced their treatment within 31 days of their diagnosis. So all in all, just some of the highlights in terms of some of the performance that we delivered throughout the year. We are continually looking to improve, and we will take on board your suggestions of areas that you may feel you could help us with as part of the later discussion. Other than that, I'm handing back over to the presenters, Pete, Fiona.
Thanks, Martin. So back to Fiona, and we're going to be looking at the future, especially the developments in the next 12 months. So, Fiona.
Thank you. I wonder if I could just take this opportunity to ask people, if you're on camera, if you could go off camera in terms of recording, so the presenter obviously sticks out when the recording is. Thank you. There's just probably one other person. Thank you. So as we move on into 23, there is going to be quite significant change within the NHS in terms of what we would call the landscape, how it all looks. Having been around the NHS for a few years, 1 or 2 years, these things happen, and it is my job with the team and the governing body of the CCG to make sure things are safely landed and that our patients and our public continue to have the services that they need. So I'm sure many of you will have seen that from April 2022, the CCG will be disestablished, and we will be part of a bigger integrated care system with Cheshire and Merseyside Health and Care Partnership. The language has changed recently. There will be something called an integrated care board, and that would be at Cheshire and Mersey level. That will be overseeing all the NHS funding that comes into Cheshire and Merseyside, and operating with the what they call place-based partnerships, of which Sefton as a borough is one of those 9 across Cheshire and Mersey. And that integrated care board at Cheshire and Mersey level will work alongside an integrated care partnership up there, which will have lots of representation from each of the, well, say it will have representation from each of the local authorities. It will have different representation around the table, and it will work hand in glove with the integrated care board to ensure that the needs of the populations within each of the 9 places. So, for example, our borough of Sefton, it's really focused on our community. So within the context of the changes, there will be a real focus continuing within Sefton. And we've been working really hard with the council, with our newly emergent primary care networks, and with all our local partners, including our community voluntary faith sector, to support this transition from where we are. So as we don't throw the baby out with the bathwater, that we take with us all the good things that we've been doing and continue the improvement journey, which Ali is going to go into more detail in after I've finished. So the most important thing on this slide is, yes, things are changing from April 2022, but we have been working really hard to create and sustain going forward a partnership that is rooted in the borough of Sefton. Next slide, please. So you all will be very familiar with this map of Sefton, from the top end at Southport, top end of Southport, to the bottom end down in Bootle. What we're trying to demonstrate here, and I do hope it comes across in this slide, is that there will be 3 primary care networks. So the whole of the north will be covered by the Southport and Formby PCN. And then down in the south, we've got 1 PCN. You can see the line that goes left to right that covers Crosby and Maghull, and then the element of Seaforth and Litherland that's contained within the primary care network of Seaforth and Litherland. And each of these 3 networks have a clinical director. So they're taking the good things out of clinical commissioning groups, which is the clinicians that deliver care on a day-to-day basis. This won't be about commissioning, though, as a primary care network. It will be about coordinating a network of provision. So really building up with community services, with community voluntary faith sector, with our local authority, with our communities themselves. The people who understand the issues aren't, you know, I've learned a lot in 15 years about Sefton, but I'm not a resident. Those of you who live in Sefton are best placed to talk to us about need, and we collect obviously the information through the needs analysis that we do, and through that we then look to commission. So the primary care networks are really pivotal going forward in the new landscape. They will work within the context of Sefton Local Authority's 3 localities. So those 3 localities have been created a good few years ago, probably at least 5 now. They're not absolutely what we call coterminous. They're not absolutely mirroring each other, but what we do is ensure behind the scenes that that we all work together to make it work, because as our public, you're not necessarily interested in how it's all put together. What really matters, as it does to me and a patient where I am a resident, is that when I need care, people will pull together and coordinate that care, and I don't have to be passed around. And we're really working hard to integrate our care. So this is the model of what we call the architecture. So what we're doing to add all the little building blocks together, a bit like Lego, where we're trying to put it all together to create a cohesive whole where we really work together in an integrated fashion. Next slide. This is probably a little bit more detail. So you can see the blue lines here are the 3 localities that the council operate out of. You can see that the north locality is absolutely coterminous, so it sits alongside and mirrors the PCN up there. And then you can see the overlap with our Crosby, Bootle and McGull and the Seaforth and Litherland primary care networks, some of which is in south and some of which central. The localities that we have in the CCG's commissioning are around about 30 to 50,000 population. And whilst commissioning might be done in a little bit of a different way, in an integrated way at a local level in the borough with the local authority and alongside our providers, rather than having a commissioning and provider split, what we're doing with our localities is really trying to develop integrated neighbourhood teams. So really getting down to a level where the GPs with the pharmacists, the nurses, whichever care professional, both what I would call statutory, so health services and social care, are working alongside, you know, community voluntary affairs sector, are working alongside the communities and the populations. And we need to do more of that to build up that understanding and to really be able to move forward with providing for the needs of our population. And our populations are also different. I don't need to tell you that as our communities. So it's really making sure we can be, and this is what the PCNs are there to do, is really tune into the needs of the local population. So you're not necessarily going to have everything repeated across the 8 localities in the same way. You're going to get the particular services directed to the needs of those local populations. So there might be more of services, one service in one locality than others, because that's the need of the population. Next slide, please. So what have we been doing as a CCG to support this transition? So this is not work that I've just been doing in the last 12 months. We've been building up to this for the last sort of 5 years, unbeknownst that all this would change. I don't have a crystal ball. I would be a very rich woman if I did. It's about, for me as the accountable officer, supporting the future. So as of the 1st of April, the CCGs will be disestablished. My role will no longer exist in the format that it is. So this is about making sure that there is solid and firm foundations for our future. So we've been working to support, the CCGs working to support the primary care network developments. We've got 3 clinical directors, and we're very fortunate in Sefton that we've got experienced clinicians in those roles. We've been working together with our providers. They were all on that list before in my previous slot, to really understand how we can work together cohesively and not in silos. Working with the local authority, because a lot of what we do in commissioning we could do better once and together and spend the Sefton pound in a much more effective way, we believe. And then, of course, acute and specialist services, particularly with the shaping care together, much of that will probably be done at a Cheshire and Mersey level. That we are making sure that as the Borough of Sefton, we're really clear about what services we need supporting in our borough to deliver the care that people need. Okay, next slide, please. So it's no coincidence this is an upside down triangle. I've not gone mad. It's all about you guys in that blue box. You know, people at the top of a pyramid, often it's the other way around. And I've always behaved like this, I hope, in the years that I've been allowed to serve you, which is nearly 9, that we're looking at what people need and working from your needs upwards. So with this triangle is just demonstrating that even in the new world, 80% of what will happen in the work that the CCG does will still happen one way or another with those elements of primary care networks, integrated commissioning, the provision coming together, sitting alongside commissioners, and the work that we need to do to influence the integrated care board at Cheshire and Mersey level. The majority of that will be done at a Sefton Borough level to serve our population. And I think that's really, really important for people to understand who are concerned about these reforms. This is another way of trying to focus and get into the health needs of the local population and do things once at a Cheshire and Mersey level where it makes sense to do so. We've got some real fundamental challenges in workforce, and you know, everybody at the moment's fishing in the same pond. So workforce is a really good example where we've got some specialist areas where actually, if we did it once well across the nine places, not all the boroughs, the city as well, we would be able to perhaps have much more efficient and effective services. So I do appreciate the change for some people will be of concern. I don't know what the future will bring, but what I understand as I leave in terms of my role is that Sefton, I believe, is placed in a really good position for the future. Next slide. Thank you, Chair.
Okay, we'd like to invite Eleanor up, who's in a shared post between the council and the CCG, to go through some of the future of health and care, the focus on the social aspect.
Oh, thanks very much, Pete. Thank you. Hello, everyone. Thanks for having me. Yes, so as introduced, my role is Integrated Social Care and Health Manager. So I'm responsible for working to navigate around this concept of integration that we've been working towards for a few years now, and we were about to see accelerate by some of the legislation that I'm going to give a bit of an overview of in my presentation. So thanks, everyone. Thanks for the slides, Jonathan. Happy to move on to the first one, please. Thank you. So integration, you're probably all familiar with this term. So I've tried to just explain really the key drivers around it. It's a long-term aim for Sefton Health and Care Services, and it's been a long-term policy aim of successive governments over the last 3 decades. It's seen as a solution to trying to continue to meet the challenge of addressing people's needs, delivering value for money in terms of making the most of the resource available to us jointly, removing duplication, making sure we're getting it right first time for people that are receiving our services. So that concept of tell us once, so you're not repeatedly explaining what you need in terms of health or care support from the system. You've got that single account of what you need, and the system as a whole can wrap around and offer the best bits of the system around what the individual needs. So it's about avoiding duplication, so making sure we're as efficient as possible and we haven't got different parts of us trying to do the same thing. It's about us all pulling together in the same direction, as Fiona's outlined, around trying to make a difference to the health and wellbeing outcomes of people that live in Sefton, regardless of which bit of the system we work in. And it's about us all working with the focus of the individual in front of us and the outcomes that we're trying to achieve for that individual, and locating the best way of getting that for them. So thank you. Next slide, please, Jonathan. Thank you. So as mentioned, it's been something we've been all working towards as a kind of social policy aim through a long time. But what's changed this time, and what will make it different? We're optimistic, I'd say, as a group of health and social care professionals in Sefton, and our wider partners, that what's different this time is that we've been given the tools to do that, and the legislation which allows us to do that. Previously, inadvertently, sometimes that's been a barrier. There's been artificial divisions created and handovers created by a myriad of different rules and regulations. And this time, with that being cleared, the ways being cleared to allow us to focus on achieving those outcomes. So bit of a recent potted history of how we've come to the point we find ourselves at today is back in November 2020 to February 2021, NHS England led a consultation you might have seen called Integrating Care, Next Steps to Build Strong and Effective Integrated Care Systems Across England. So it talked about what we could do together to reduce that bureaucracy, have really effective decision making, have ways of pooling our money and having plans to spend that money based on what we know people need in Sefton, or whichever area you happen to be in. So following on from that consultation, the government published a white paper back in February of this year called Integration and Innovation, Working Together to Improve Health and Social Care for All. The quote there you can see on the screen was part of the introduction which states this bill is about backing our health and care systems and everyone who works in it. Our proposal builds on the NHS's own long-term plan and outlining steps to support people who work together to meet people's health and care needs. Taken together, they will help us build back better after COVID. And I think that's the other thing that's different this time, as we've heard a little bit already earlier this evening, the lessons we learned during the COVID response, when we were purely focused on the person in front of us and what we could do to make it better, and we were purely focused on working together and forgot a lot of those boundaries and barriers and really just pulled together to get the best out of the system. I know we've heard some of the successes that Fiona outlined, for example, our vaccination process, and many of us involved in the call worked really closely together to mobilise that and vaccinate, for example, the highest number of care home residents and staff in Cheshire and Mersey, for example. And a lot of that is credited with just working together and just being focused on doing the right thing. So that's another important point to pull out, really. And then in July of this year, the 6th of July this year, we finally saw the Health and Care Bill laid before Parliament, which made plans, set out the plans of how these things will become the law and become statutory obligations on all of us involved in the planning and delivery of health and care to have an effect from the 1st of April 2022. Thanks, Jonathan. Next slide, please. So something I just thought it's important to acknowledge, the Health and Care Bill made some changes to the terminology that you might have previously heard. So just for clarification purposes, really, these are the key building blocks of an integrated care system defined by the bill. So place-based partnerships at the top there in the yellow box is what we would call us in Sefton. So it literally just means the boundary of Septon and the people working together. So it's defined in the law by the health and wellbeing footprint. So it incorporates all of us that operate in Sefton as a geographical borough. So the integrated care system bit at Cheshire and Mersey level is defined as an integrated care board. You may have previously heard that termed as an ICF NHS body. So that will be a board that's responsible for the delivery of NHS services within Cheshire and Mersey. So that board will have to interact with the place-based partnership to make sure it's doing that on the basis of what people in Sefton need. The other building block of the system of the Cheshire and Mersey bit there in purple is the integrated care partnerships. So again, you might have heard that referred to previously as the ICS Health and Care Partnership. So that's a collective term for the body that organises all of that and works together to direct the funding, resources and the delivery of the NHS plan by its interaction with the place-based partnership. Some things will happen at a system level and some things will happen at place. So it's basically on the principle of where it makes sense to do it once across those nine places, to do it the same way but 9 times over, or to do it differently 9 times, those 9 places underneath the Cheshire and Mersey banner of an integrated care system. So that decision is based on where the outcome that is needed for people, reducing variation wherever possible and making sure it's the best way to get the best outcomes and the most effective way to use the money available. The other key part of that is referred to as provider collaboratives. So this is where providers of certain services are asked to come together to work together as a collaborative to deliver the best outcomes. So this is enabled in the bill by delegated decision-making abilities and resource budget abilities to joint working provisions. So, for example, in Cheshire and Mersey, we'll see that happening across acute hospitals and in mental health services. So all the providers that are involved in delivering that will have to come together and agree a plan of delivering that the best way that they can. basically. So those 4 building blocks interact to deliver what you feel as services, as hopefully improved services and improved outcomes for people that live in Sefton. Thanks, Jonathan. If I could have the next slide, please. Thank you. So these little diagrams are just to help articulate what we're being asked to do as place-based partnerships, so the Sefton bit. So we're being asked to develop place-based leadership and collaboration, so a joint decision-making and a joint commitment to work together to achieve those outcomes we know we need to achieve. A commitment that will do that by listening to our community, so making sure really at the heart of it is the voice of the people that use the services, those experts by experience they're sometimes referred to. We'll need to plan services together, so to make sure we're not doing that separately, but we're just looking at the whole spectrum of needs. So, for example, if it's around community mental health services, that it's everybody involved in that. It's community health providers, it's social workers that are involved in that. It's the voluntary sector organisations that help deliver some of those services, for example. So that's the planning and delivery of it. Population health management there on the bottom refers to the fact that everything needs to be driven by what we know, so what the data tells us. Like, for example, we might have different levels of need in different parts of Septon, so the ability to plan and deliver things in a flexible way that is most appropriate to the smallest possible group of people, basically. That's all with the driver of improving quality of those services, making sure we're making best use of the resources and making sure that we're valuing and developing the workforce that deliver those at the same time, in the broadest possible sense, any workforce that's an expert in the area that they're delivering it in, not just by kind of individual organisations. So we'll be asked to make sure we've got workforce plans around that on an integrated basis, got financial plans about that. We've got accountability frameworks that hold us all to account. So we're all measured by whether or not we're delivering against those health and wellbeing outcomes for our area. That we've got a clear way of engaging with residents and communities. Obviously, discussions like we're having tonight is a key part of that. That we've got an operating model, so the way we're organised and how we make sure we're working together. And we've got a plan, and the plan is articulating, as Fiona talked about, that joint vision of what is already in the health and wellbeing strategy and what's in the local NHS 5-year plan, Sefton Together. Again, all driven by a combined picture of need and data that we're doing by compiling all that intelligence and information we hold separately as a collective tool that drives that forward. So I keep referring to it as it's not necessarily changing what we know we need to try and change and the needs we know that exist in Sefton, but it's changing the way we organise ourselves around that to give us a better chance of having an impact on them. Thanks, Jonathan. Next slide, please. Thank you. So in terms of place-based partnerships, so in terms of how we work in Sefton, we're being asked to do that on an all-age level. So we're simplifying and modernising care and service models. So so that means right from children up to end of life. So that we're looking around thematics of start well, living well, ageing well, and providing a good positive end to life. It involves public health and wider community development offers. So we should be thinking about things like economic development, for example, education, housing. So it's that really driving at the things that contribute to good health and well-being in kind of the widest possible sense, sometimes referred to as wider determinants, you might have heard of. So the push is that things must, wherever possible, be community-based. So it's thinking about what we can deliver in our resilient community. So social prescribing activities, working with our voluntary sector, local access to our green spaces and leisure facilities, a key asset to Sefton that we could build on more and link more kind of strategically to how that affects people's health and wellbeing outcomes. Really important part of it is our primary care network, so how we work with those GPs and primary care professionals who are the ones at the real heart of need in the community, and knowing what people really need and what they're seeing presented at their door every day. Really important to include community mental health. That's got to be a real important focus. We know that demand for those sorts of services is increasing, and that is especially affected by the impact that COVID's had on our community. Some parts of urgent and emergency care will be delivered through those networks, as we talked about, but it's about how we influence that and make sure it's right for us as Sefton in our place-based partnership, and how we help to support those with long-term conditions. So thinking about building, it's sometimes called an asset-based response, of how we build on skills and expertise and resource that we know people already have themselves or could be linked to quite easily. And we sometimes refer to it as I've heard it referred to as give someone the nail. What's the little bit that would make a difference? And I often think of an example whereby I've got a long history of working across social care and health services, and I always think of an example where we had a gentleman that had a stroke and was being supported by dom care providers for the one aspect of his life that he hadn't been able to manage following that stroke, which was cooking tea for his children. And the response from the system was to prescribe a care package to go in every single day and make that food for the children. And actually, when you stripped it back, that wasn't what they wanted as a family unit. They wanted the ability to make the tea. So we worked with housing providers to remodel the kitchen to allow them to do that, and a short, sharp intervention around building those skills and resilience around managing that if anything goes wrong, and having backup plans if support is needed. But actually the aim being that person didn't need a formal intervention, they needed something to solve this one small problem, that if they were able to do that, they could carry on living a fulfilling, positive, healthy life where their mental well-being was benefited, it was the right thing for the children, etc. So sorry, just a little aside there of an example that often pops into my head of what we mean by that sort of thing. And of course it incorporates social care, education, housing, employment and training support, as we talked about. So that idea that you're wrapping all the things that people need as building blocks to having a healthy and sustainable lifestyle, not just viewing each of those little things in isolation. Thanks, Jonathan. Next slide, please. Lovely, thank you. So the Cheshire and Mersey system as a whole has these 4 overarching core purposes. So this is a key part of driving at us doing the best we can. That's around improving outcomes for population health and healthcare, tackling those inequalities in outcome, experience and access. I think that's really important for Sefton, because I'm sure people on the call are familiar that a really interesting fact about Septon is that disparity of healthy life expectancy and that polar kind of positioning that we have in people's health and well-being outcomes in terms of their income, their expected outcomes in life, and we really see this as an opportunity to build on that and see if we can reduce that as one of our measures of whether we're doing the right thing and done a good job. Of course, we must be focused on enhancing productivity and value for money, because that's how we'll be able to keep meeting outcomes. Rising demand, people living longer with more long-term conditions, will be about us using the money we've got available to us the absolute best way that we can to get the outcomes people need. And it's about helping the NHS to support social and economic development. So recognising that people having stable economic positions and stable, comfortable social positions in turn contributes to their need for more critical NHS services, and that our focus for all of us should be about prevention and building people's resilience and toolkits to be able to keep and maintain health and well-being. Thanks, Jonathan. So what will be different? So this slide just tries to summarise what we expect you will feel as different going forward. So we've got this one team approach. So that's that concept I've touched on about us all being empowered to be free from organisational barriers and using our joint resources. So that's to stop thinking about who pays our paycheck and what we're trying to deliver against for that one organisation, and to shift that way of thinking across what can we do with the system as a whole and how do we make a difference across that spectrum. We want to have a system that allows us to make decisions together, so that we as professionals aren't spending lots of time going to separate meetings discussing similar things in an attempt to change things, transform things, make things better for people. Actually, if we had single routes to do that and accountable ways that people are all signed up to, we'd be able to have that conversation once and get on with the doing more, is the dream. And then the key enabler of that will obviously having pooled budgets. So again, the legislation allows us basically to put our money in a pot together, and to use that to its greatest effect for the people of Sefton. What people in Sefton need isn't changing, as we've touched on. We're aware of those. A lot of them have been long-term needs that, despite best efforts, we haven't seen the improvement that we would all really have the ambition to see. So actually, this is about the way health and care systems meet those needs. We're changing the way we do it, and we organise ourselves around it to empower the system to make a difference, as opposed to just keeping going through doing the same things that we've always done, but separately. Thanks, Jonathan. If I could have the next slide, please. Thank you. So as Fiona referred to, a really important part of this is being signed up to that one vision, which is articulated through the existing Sefton Health and Wellbeing strategy. So this strategy, sometimes referred to as Living Well in Sefton, came into being on the 1st of April 2020 and runs for the next 5 years. So the requirement to have health and wellbeing strategies exists in law already through the 2012 Care Act. So the new Health and Social Care Act just reinforces the role of health and wellbeing strategy as opposed health and wellbeing strategy, and health and wellbeing boards, as opposed to creates anything new. So again, it's trying to make the best use of what we've got available to us. So we've got a well-established board in Septon that's been in operation since 2014, and this board is developing and growing into being the key steward of the system, is a term that's sometimes called the key driver, that can see all those connections and can hold all of us as different organisations to account, to making sure what we're doing is making a real difference against these key ambitions for people that live in Sefton. These 10 key ambitions you can see displayed on the screen are key ambitions that have been work included on following extensive public consultation based on something called the Joint Strategic Needs Assessment. Again, this is an existing legal requirement for all of us to look at the data that we know about life expectancy, about the long-term conditions that are most common in our area, for example, the things that we perform worse at compared to other areas in the country and comparator areas, so similar size areas, etc. that you would so are we doing what you'd expect us to do, or does it highlight to us there are areas we need to do more on? So these 10 ambitions are articulated through the health and wellbeing strategy, and also grouped by what we call life course areas. So start well, that's for our children and young people. That long held ambition you might have often heard referred to as every child deserves the best start in their first 1001 days. So it's a real big public health evidence body behind that it's absolutely critical to everybody's long-term outcomes, that first stage of life and getting the best that they can. Obviously, education and training needs, that every young person has that opportunity to unlock the door to the most opportunities and choices that they have, that they'll have a successful transition to adulthood. So we're not making that more difficult for those people that will need care and support from childhood through to adulthood. In terms of Live Well, that's looking at health and wellbeing services in Sefton working together, so that everybody has fulfilling roles that support their needs. So that might be employment, it might be through volunteering, things which give people that sense of wellbeing and achievement, and that the wider system's got a strong role in making sure we're preventing things getting worse, and we're going in there early with those small changes that will stop people compounding it and reaching a crisis position. For Aging Well, we want our older people to stay active and connected and involved for as long as possible. When they do grow older, we want them, as people do grow older, we want them to be provided with tailored support that meets their needs. So listening to what a person needs and being able to wrap that around them, instead of just saying it has to be a care home placement, it has to be this. It could be a little bit of telecare, a little bit of a community and voluntary sector around social inclusion, for example. So that's what that concept means. And we want our community and built environment to meet the needs of people as they get older. So thinking about accessibility and public transport, for example, access to green spaces. And for all of us, we want any age that you are, we want the place where we live, Sefton, to be easy to be healthy and happy in, with opportunities for better health and well-being on our doorstep. So people, that we're building the conditions for people to be able to live a happy and healthy life. Thanks, Jonathan. If we could go on to the next slide, please. The next slides will articulate some of the things that we know across the life course we need to get better at. So this diagram depicts the things that we've improved on, the things we've got worse on, the things which are getting worse, the things which are staying the same. And again, this helps inform that place-based strategy, what we should all be focused on in Septon. So again, these won't be unfamiliar with people. We know there have been things we've been trying to work on for a long time, such as obesity, such as heart disease, such as liver disease, number of people living alone, for example. Injuries due to falls is another area that we're really keen to get better at. Self-harm, hospitalisation admissions for our young people is an area we're all focused on trying to get better and reduce. So there's quite a lot of information in there, but hopefully that just helps people understand that locally we already know what we need to do, but this is a chance to organise us all around this life course. Thanks, Jonathan. The next slides that hopefully Jonathan's just loading will articulate the ambitions again that you will be familiar with through Sefton Together around healthy balance. As I touched on earlier about that difference in healthy life expectancy in some of our poorest and richest parts of Sefton and how we can reduce that gap, making sure that people have the expectation that they will be given help to live as long as possible in the best possible conditions. Again, early intervention, prevention, empowering individuals with self-care, building that resilience and toolkits for people to just access that little bit of care when they need it. And the ability to expect, quite rightly, that they'll be able to access high quality services when they do need them in a timely way. So hopefully these slides are illustrating that we're already aligned. We already knew what we needed to do together, and this just helps us build on that. Thanks, Jonathan. If I could have the next slide, please. This slide will be a continuation of those Sefton Together ambitions around delivering the long-term NHS plan. So obviously that still exists and we still have clear expectations which will be filtered down through Cheshire and Mersey about what we should be doing to meet the national NHS long-term goals. That might be around maternity services, for example, reducing inequalities in health services, tackling diabetes, and obviously mental health focus is a national and local key issue for all of us. Sustainability around making sure, again, that value for money, and we're creating services that that are able to keep going and keep improving, but also as we've talked about, kind of removing that need for reliance on service by empowering people and preventing needs getting worse. Social value is a really key aspect of it. So this is about considering the fact that the NHS in Sefton and other public sector providers such as social care, such as our community and voluntary sector, are something that's called anchor institutions, same as our schools and our GPs, have a really important role in our community, and they have ability to consider things like how they're spending, how we're spending money, making sure we're employing local people, have we got lots of apprenticeships, for example, are we reducing our environmental impact? And again, the Sefton Together did illustrate that principle of working together. So again, just to illustrate, it's a long-term ambition. We're just getting a bit of a helping hand to do a better job at that, hopefully, in the next few years. So next slide, Jonathan, please. This slide is just to articulate that there's a significant amount of money spent in a combined footprint across the CCGs and adult social care. It's actually 748 million. So that's the opportunity available to us. That's the budget envelope, and we've got the chance to make sure we're more confident that we're directing that in the right way. Thanks, Jonathan. Next slide, please. Thank you. This slide just I'll just rattle through it. I'm aware we're running out of time, and I've got a fancy quiz questions too for you. So some of our most pressing needs is to start to test out those different ways we're working. Some people around the table might have been involved in the mental health review, for example, helping people as early as possible to have the tools they need, strengthening community engagement, putting together all we know, that data intelligence, being able to demonstrate our readiness, so we're getting everything in order to be able to say we do know what we're doing, you can trust us with that extra money and responsibility. Ready for April 2022, when we'll become a Sefton integrated care partnership or a place-based partnership, so the Sefton bit. Thanks, Jonathan. Next slide, please. I think the next slide, we wanted to include some examples of where we've achieved it. I think we have touched on that. The mental health review, big review of adult mental health services led by the CCG and the council, looking at data analysis, partnership development, what really matters. That's been a really inclusive it's a process, and then that will feed what becomes our mental health programme together that we'll then deliver against over the coming years. Thank you, Jonathan. The next slide articulates the care home forum. So this is, again, I've already touched on this, I think, which is around the fact that during the COVID crisis, we came together to coalesce around care homes and what we could do. And we had some, when we're faced, it's a good example of when we're faced with a terrible situation under those extreme circumstances. We did that. We met every single morning at 8 AM at one time, and different people in the system said, today I will make this happen, to do things like, for example, make sure we had PPE available, make sure those care homes had enough staff when they were experiencing extreme pressure around that, making sure we worked with medicines management colleagues, so right medication to get in there, work together to make sure we had state-of-the-art visitor policy so we could bring back visitors safely and as soon as possible. And now we have a continued commitment to work together through an integrated strategy. Thank you. I think the next slide, Jonathan, just illustrates a kind of operational on the ground example of this, which is our Sefton integrated care teams. So this is where teams come together with something that we call a multidisciplinary team, which brings together people from across different health partners, social workers, occupational therapists, physios, GPs, health visitors, bringing them together, teams clustered around GP surgeries to be able to direct the right resource to what people need around them. Again, moving away from working for your siloed organisation, but working around the locality that you're responsible for and what people need. Thank you, Jonathan. Next slide. So the final section of my time with you this evening is to gain some of your views using the very clever polling tool. So we have two questions that we're going to ask using the polling tool, which was based on what you've heard and your knowledge already. Do you think that Sefton organisations working closer together will improve services locally? And a second question about, do you feel that these proposals align with our local plans that we already had in place, Sefton Together and Living Well in Sefton? So you should see on your screen the first question. Do you think that Sefton organisations working closer together will improve services locally? And you should now have the opportunity to click yes, no, to some extent, or not sure. So if you'd all like to submit your response, that would be really helpful. Thank you. That's great. Thank you very much. So now you should be seeing your second question, which is, do you feel these proposals align with our local plans, Sefton Together and Living Well Sefton? Again, We've got yes, no, to some extent, or not sure, and then submit. That's great, thank you very much. Lovely, thank you. So I think that brings my section to an end. So I'll hand back to the chair. Thank you very much, everyone, for listening. Thank you.
Thank you very much. So we'll be moving on now to the final section, which relates to general practice in Sefton, and we'd like to welcome Jan Leonard, who's one of the directors for Place in South Sefton, to kick us off.
Great, thanks Pete for that. So I'm going to talk to you a little bit about general practice, and it's something I'm sure you can all relate to, and you've all had experiences of. So it's been a really challenging 18 months for our practices. One of the key things you can remember back to the start of the pandemic was, how do we keep our patients safe? We were facing something we didn't know before. We had real challenges with infection prevention control, how to implement social distancing in lots of our practices, which are tiny Victorian houses. And we've overcome that. We worked really hard. We worked with partners, and practices worked together to keep our patients safe and our staff safe, because our practices are small, and it was easy to take a practice out if we got an outbreak of COVID in a practice. We did that really successfully and kept the doors, I'll say figuratively, open anyway, and kept seeing patients face to face. What we are seeing though now is huge rising demand. So our practices are seeing far more contacts now than they were before the pandemic. If we go back to 2019 and compare, and if you just look at some of the numbers on the screen there in terms of the number of phone calls that they're taking, the number of telephone appointments, and what we've seen is a huge variation now in the ways you can contact a practice over the telephone, face to face. We've got things like eConsult, where you go online and do a digital consultation, and you can see there the number of video appointments that we've done. And when Ellie was talking about care homes, they've been really successful in care homes, particularly when care homes didn't want to let lots of people in because of the infection risks, and so things like video appointments have been really helpful there. And I think the other thing to say is what those numbers mask is that we delivered a vaccination programme throughout all of that as well. So way back in December, when everyone was looking forward to what they hoped would be a normal Christmas, our teams were busy trying to plan how we delivered a huge vaccination programme, and we have done that really, really successfully. If you go to the next slide, please. So what are we hearing? So the National Patient Survey is a survey that's done every year. It's done by Ipsos Mori, and this data that I'm reporting on now was collected in January. So, we'd been living with COVID for quite a while. And what we hear is that over 80% of South Sefton patients are satisfied with the care they receive. There's, again, a really good number of patients who find that they have a good experience in making an appointment. And I'll give you a minute to read some of those. One of the really important ones there is that 90% of the time patients felt listened to and treated with care and concern. And that's really important, having that confidence in the professional that you're seeing. And again, this isn't necessarily just about GP care. This is about the whole multi-professional team at the practice. And in a minute, Pete's going to talk about a day in the life of a GP. But I think the thing as well to say is that practices, not only are they dealing with sort of patient contacts, but it's all the plethora of stuff that goes on in the background, like prescription requests, referrals. Every time you have a blood test done, someone will look at that and act on it in your practice. There'll be queries coming in from, say, hospitals, if you've had a hospital appointment. So there's a huge amount of back office activity that's going on as well at the same time. So I think there's some real positives out of that. We recognise that this is a survey, so it's an average, and not everybody's had their voice heard, and also that there is variation between our practices. And one of the things we want to do is understand why that is the case, and how can we bring the standard up for everybody. So if we could go on to the next slide, this is some of the things we're hearing, and some of this is coming in through the CCG. Some of this is from our partners at Health Watch, who we've worked really closely with on access. So Again, we hear that practices haven't been open during the pandemic, and that just isn't the case. Those who've had a clinical need for it have been seen. And after, I'll go on to some of the other services that we did step up during the pandemic. Again, lots of people saying they only want to see a GP and not another healthcare professional. And again, I'll talk a bit more about that later on. We've got a huge range of professionals working in general practice now, lots of whom are really specialist in certain areas and far better placed to advise than a GP. Apologies to GP colleagues there. And this thing about, you know, there are no face-to-face appointments. Face-to-face appointments are being available throughout for those who clinically need them. And then eConsult, which is our online tool to have a consultation. Again, that's proved really successful, not for everybody, but it is, you know, in terms of particularly doing some of the admin tasks you might be consulting for. And lots of people find it helpful if they're working or if they've got things that they're perhaps a bit embarrassed about and they don't want to face somebody, you know, and they can do it online and get a referral that way. So there's a real mixed bag here of things that we're hearing about access. Now, I'm going to pause here and hand over to Pete, who's got some slides to talk about what it's like in the day in the life of a GP.
Thanks a lot, Jan. That's great. So I'm going to talk a bit about the background to the situation that we're in at the minute, and I'm also going to share a day when I obviously have to do this. So the comments was, well, what about if you just record last week or this week a day? So Monday, that was the day I recorded. But the decade that was. So we're in a situation now, we're often kind of asking questions. People are asking questions in various ways, but it's very important to understand the foundations and the background to what's led us to where we're at. 2010 to 2020, the NHS was under an austerity kind of programme with effectively flatline resource. And previous to that, the NHS had seen 4% increase on average year on year to help manage demographics, treatment costs, expectation, and advanced clinical quality. If you know anything about compound interest, you'll appreciate that's a lot of money over 10 years. Shortly after 2010, the Department of Health own GP guru, Sir John Oldham, predicted a tsunami of need that was going to come in the next 5 years, and that people needed to change what they were doing and address this urgently. Otherwise, practices and the health service would become overwhelmed. That he's well quoted in academic papers, health service research, etc., but it wasn't really taken up massively at the time, albeit the government in 2015 did promise an extra 5,000 GPs, and we all kind of breathed a sigh of relief. The cavalry will soon be here. Unfortunately, that didn't transpire, and 5 years later, the number of whole-time equivalent GPs that we've got in the country is 100 more. As the kind of the pressures increased to the latter end of the decade, we started to see CCGs and local systems come under financial pressure to ensure that they were maintaining the level of care that patients required. And this was mainly in areas of high frailty, and as Sir John Oldham predicted, the tsunami of need was soon upon us. Well, during this time, the number of patients under a practice increased, partly because of mergers and partly because of increase in population, but the number of GPs per population went down. And that actually kind of put us in a precarious position, so that general practice was under significantly more pressure at the end of the decade than it was at the beginning. And within South Sefton, we started the decade kind of quite low down in the national kind of stats for resource, but it wasn't really, if it wasn't for the CCG leadership, some of the people on the call here tonight who sought to kind of invest through the local quality contract to bring that funding up to basically national levels, we could have been in a very precarious position indeed. So if we go to the next slide, thank you, Jonathan. These two graphs basically help explain what I've just said. And interestingly, graph on the left, has got the different nations, and you can see England, which is the kind of the one that's unfortunately going down after 2019. And the other point to mention here is that the complexity. You know, back in 1960, there were no drugs to treat heart failure, and in 2020, there's 15 different drug classes. not different drugs, drug classes. And most patients will be on, 5 or 6. You then kind of expand that out to other conditions, hypertension, COPD, etc., diabetes, and you start seeing, wow, this is kind of logarithmic numbers of medications, monitoring and safety that a general practitioner needs to do. A lot of stuff which used to be managed in hospital. The graph on the left shows that actually the 2 bars are kind of pre-pandemic, but actually the increase in the demographic is the population is mainly in the older patients, and it's in the very old as well as we move into the kind of the next 25 years. And in fact, we're going to see a 50% increase in over 65s over the next 25 years. The stark contrast is it's going to take 25 years for the NHS to have the average number of doctors per 1,000 population as the average developed nation. That's how far behind we are. So it's going to be a tough next 25 years unless something radical happens, and you can't create highly skilled professionals overnight. Does it really matter about the increase in demographics? Well, the next slide basically helps us understand a bit about the pressures on GPs and just maps out the number of attendances different people have according to age and sex. And what you can see is that compare a male of 40 to a male of 80, and just on appointments alone, it's 4 to 5 times. And then when you account for other work, drug monitoring, investigations, correspondence, you're talking ratios of 6 to 7. That is where basically that number comes from. And so this is quite a significant change, only a small amount in patient changes in the demographics that leads to a significant change in workload due to the type of long-term conditions that we're managing, which in itself is a success of the health service and something we should celebrate, but it's certainly something that's bearing down. So we'd reached saturation, and then of course 2020 we hit COVID, and COVID-19 has got far-reaching effects. So if we go on to the next slide, just to explain a little bit about what it meant to be a GP. Because of the isolation rules, practices were on a knife edge. We'd often go in and there would be 1/3 of our staff would not be there, and they would either be sick or they'll be isolating, or we'd have to try and sort something out from IT, and our IT colleagues did a sterling job trying to help us with that. But it was a huge kind of pressure and deficit to have sometimes 1/3 of your staff not there. So the NHS triage model, which went to telephone first for safety reasons, actually demonstrated an increase in appointments compared to the year before, 3.5 million, and that's not including vaccination appointments. So GPs started to see that the workload was increasing, and they could actually experienced GPs could manage more patients within the same time frame, albeit you're kind of holding the line a lot of the time. We saw a 400% increase in e-consults, which is obviously a huge amount of change, which is open access, and the backlog that hospitals are having to manage with 5.5 million people have almost all had to go through the general practice system, as GPs are the gatekeepers often who make those referrals. So a huge amount has gone on to the GPs, and in the last few months, the actual kind of figures demonstrate in A&E and in GP, which is emergency primary care effectively, we're exceeding the depth of winter in 2019 on the demand. So we're facing the most severe pressures in 70-year history, and that is really important to understand as we seek to kind of like engage on this argument. Are GPs obstinate and idle? Are they stretched beyond endurance? To lay the bare truth, we need to go under the radar. So let's go under the radar, and this is a little bit of a summary of Monday. Typical GP partner. In fact, I'm pretty average probably on Monday. So I logged on at 8 o'clock and tried to move as many prescriptions to the pharmacist as possible to ensure that they could process them. And then the surgery, which is scheduled from 8:30 to 11, just always goes over because you can't manage the patients within 10 minutes anymore. And we'd seen a mixture of telephone and face-to-face. Some people we're bringing in that day, and others are working in Liverpool city centre, and they are very happy to speak to us on the phone. But in amongst those patients, we're being interspersed with urgent tasks. We're getting requests. We're asking for clinical support for nurses and other staff. So there's a lot of other things going on, which can be quite disorientating for junior staff. Then we moved on. We had to supervise our GP trainee, or my trainee, who's not a GP. All her kind of consultations needed to be reviewed for safety and training purposes because she's very junior. And then we had to have some urgent discussions with the practice manager about staffing issues, contracts, the programme, etc. So then we moved into managing the home visits. We had a patient who was housebound, short of breath, a palliative care patient who needed care planning, somebody who developed acute confusion and was difficult to manage, and a patient who'd just been discharged from hospital but now had symptoms of a urinary tract infection. So after that, we tried to squeeze a few e-consults in and manage them, and then back to the next surgery. So often it's a lot of urgent stuff on call, and you know, there's often a few ill kids who've had a temperature, it's not gone down through the day, and more supervision. Now you get to about 6:30 and the door's shut. That's the end of the kind of telephone line, and that's the point where you can actually do all your admin. So on an average, you know, we might review about 50 labs. There could be 40 tasks, and there's a number of clinical correspondence requests, medication needs adding, please review the CCG, etc. And everybody's medications have to be reviewed on a cyclical basis, some very frequently if they're high risk, others not so frequently, and tasks and coordination has to occur for safety management purposes. I forgot to put in there was also a MASH report for the multi-agency safeguarding hub for 4 people in a family, which took an hour to review their cases to ensure that team could manage that family safely. So at 8:30, my wife is getting a bit anxious to get home, and so I lock up. But there's still stuff over, and that's basically another hour and a half to find somewhere in the week to kind of catch up. Now, is that an average day? There is no average day. You know, the week before I walked into the surgery on to do my on call. We had another partner who was on leave. We believe people should be allowed to go on holiday. Another GP had moved days. Somebody had a real family emergency. And then somebody's basically kid was sick. So as I walked into work, I was covering 4 clinicians, actually 4 GPs and a pharmacist, and we didn't have a trainee either. So it was feeling a bit pressured, and not long into the morning, a lady turned up who was having an acute asthma attack. We put her on a nebulizer, we monitored her, she didn't respond, she went straight to A&E. An hour later, a lady who come in for a routine check with the actual nurse just for a cardiovascular review collapsed. The blood pressure was half of what is the lower reading, which should be acceptable, and we had to get the resuscitation drugs and oxygen and get her on the trolley and resuscitate her while we waited for an ambulance. And shortly after that, a patient walked in who unfortunately had been experiencing domestic violence, and she said, I can't cope anymore, please get me to a safe house. So that was the morning, and as I say, nothing's normal, but you can appreciate, you know, it's juggling and there's a lot of different tasks. So on top of this, as Jan has also mentioned, we can't unfortunately see patients all day because we have to use time to maintain update on guidance, staff training, we have to engage in quality improvement and innovation, oversee our HR, delivery of contracts, emails, development of protocols, processing those clinical letters. We do coding, we do population searches, we do referrals for the other practitioners and professionals who don't have a system to do them. We complete the insurance stuff, the legal stuff. We engage in the primary care networks and system leadership. So there's a lot of stuff that we have to cram in, and those things take time of themselves. So I hope that gives a little bit of a summary of what it's like. I'm not sure if it's a GP behind closed doors, but the kind of like the ballpark figure is most partners are working 12 to 13 hour days, and if you times that by 5, that will be 62 hours a week. Now some people are happy to work that, but when you're not getting time for breaks and you have to concentrate 100% during each one of these episodes of care, it means that there's a lot of information on your head, it's very difficult to sustain that year on year. And that's the reason why a lot of partners, unfortunately, are deciding to move on. And we're losing our senior doctors, and the BMA says that it's a 3-to-1 ratio. So it's a huge challenge to maintain our kind of key people as we seek to maintain general practice resilience. So what have we been doing in the background? Jan's going to summarise some of the other aspects outside of the general practice consultation room, and then we're going to hear from you guys.
Thanks, Pete, for that. So whilst we're talking about general practices, there's lots of services that we've wrapped around general practice to support patients during COVID. So we established a COVID hub via the walk-in centre at Litherland, which was a really good example of how we work closely with the Merseycare, our community partners, the GP Federation, to make sure that we had somewhere safe to see patients who were potentially COVID positive. I've mentioned the vaccination programme, and that's continuing now, and again has been really successful. We've also got an acute visiting service that goes out and does home visits. So again, this was to help really make sure that we could maintain that, and it wasn't so much of an individual practice responsibility if they maybe didn't have the staffing to sustain that. And this was all about keeping both staff and patients safe. And I know one of the things that we hear a lot is about triage, and patients not liking telling somebody who they've on the phone, you know, what they need to see somebody about. And this is vital in terms of getting you, signposting you to the right healthcare professional. And I think one of the interesting things that came out in the GP patient survey was that I think 89% of people found reception staff really helpful, and that's really reassuring to hear, because they are bearing the brunt of of complaints and at the minute, and yet they are keeping general practice going. Thank you. Go on to the next slide. Are we over to you? Right, great. So any minute now, you're going to be split up into breakout rooms. So if you just sort of sit tight, you'll be whizzed away to a virtual room. There'll be a facilitator in there who'll introduce themselves. And then we've got these 4 questions we want you to answer. So what we're just going to do now is have a little bit of feedback from the facilitators in each room. So if I pick on you individually, and if you can tell me one positive thing and one room for improvement. So if I go to Suzanne first.
Hi, Jan.
This is the Eurovision Song Contest, isn't it? Go on, what's your feedback?
I'm not going to give you points. So ours was actually a very positive experience from the people that had to access GP practice in the last year. We spent a lot of time though discussing maybe the further communication needed to patients to fully understand the pressures and the situation, and sort of bust that myth that GPs don't go home at 6 o'clock when the doors close. And e-consult is definitely seen as a positive, but also we acknowledge some of the challenges around maybe if you're a patient that doesn't regularly access the GP practice and then you feel you do, how you get an appointment. But overall, I would say positive.
Okay, that's great. Thank you, Suzanne. Tracy, if I could ask for your feedback, please.
Thank you, Jan. Yes. So we had a very good conversation. I think, again, positive experience of accessing general practice once they got through the door, particularly in one occasion, but mainly also good feedback around accessing community pharmacy, some great experiences also accessing community pharmacy. A great deal of empathy about the current pressures that are being faced. And really, again, feeling that some of the issues and the pressures do need to be communicated more widely to enable that understanding to be shared. And really a good opportunity to engage with local people around a hybrid model, a face-to-face and a more online model, and really what might be the best balance of those services for local people. So quite similar themes from the previous jury.
Great, thank you very much. Jane?
Yeah, we've kind of echoed what's been said already, really. So we've had some positive experience using eConsult and getting through to CGP that way. One of the things for probably improvement would be some continuity of knowing who your GP is and seeing them quite regularly, and also a lot of empathy for the pressures within practice. And again, that communication out to the wider public to make them understand, you know, what else GPs don't go home at 6 o'clock. That has been mentioned.
Okay, great, thank you. Claire?
Hi, Jan, thank you. Yes, our group, we were small but perfectly formed, and very similar themes again. I think on the sort of negative side was around the challenges of getting through to practices. But again, it was very positive around experiences once you do. There was some feedback about sort of remote consultations, and it was actually really efficient. And you know, and I think, you know, the benefits of being able to sort of use video consultations. So overall, you know, really positive feedback, and in particular, I think, you know, Dr. Chamberlain's presentation around a day in the life of a GP was really very poignant, and again, lots of you know, sort of positive thoughts of, right, that we need to share this wider, really, with our patients, that what it really is like in general practice.
Thanks, Claire, for that. And again, from our group, again, really positive experiences of accessing during the past year. And again, our room for improvement was really the fact that not all practices are offering eConsult in the out of hours period and evenings and weekends. They felt that was it would be, you know, more convenient for patients if that was the case. So thank you so much for all that feedback. We will collate it all together, and then we can share that out with our practices, particularly some of the really positive experiences, so that they can feel that appreciation from you. So thank you very much for sharing that. If I could have my next slide. Well, we've done that, haven't we? Summary of our breakout sessions, thanks. So going forward, so I think in the groups we probably talked about this, call it a blended model, which is triage will still be needed so we can get you to the right person. And again, it is about trying to work with the public to understand that the range of professionals we've got in practice now, and that how, you know, what a skill set there is there, and how we can promote that to raise that awareness. Very shortly, we'll be coming out to patients with a survey. So you've had a bit of a snapshot really of some of the questions today, but it'll be asking those similar questions about how you found it. And those results will be shared with your practice on an individual practice basis, so they can look at, well, what their patients are saying. Because again, depending on where you are, you might need more online digital consultations available and less face-to-face. And it very much depend on what your patients are saying. And practices will discuss that through their patient participation groups. And we're working very closely with Health Watch to do that and use their support as well. So look forward to that coming soon. Thank you. And then I think that the next slide. Lastly, I couldn't finish without just promoting our fabulous vaccination services across Sefton. So they're delivered through a combination of some of our primary care networks or practices, and also working really closely with our community pharmacies. So there's a Grab a Jab website that you'll be able to access, and that's got all appointments where they are, or lots of ours are walking now. Very soon, or by the end of the month, I'm hoping we'll start our booster program, and again there'll be details available. So don't hesitate if you've been vaccinated. When you get that call, book yourself an appointment and go along. And also, I'd appeal to anyone out there who's maybe sat there and thought it's not for me, but they've changed their mind, and if they've not had a vaccination, they'll still be available. Even when we start our boosters, you'll be able to get a first dose if you've never been vaccinated. And the other thing, this isn't all about COVID. When you get called for your flu as well, please take up that offer so that we can, you know, keep everybody safe. And that's me done. Thank you very much.
Thank you very much, Jan. So it's been excellent engagement. I want to thank all the speakers, and we've just got a closing poll, but just to say the conversation is really crucial. If we can get more people conversing about their real life experiences in a way that actually can influence the system, that's fantastic. It's all part of the journey. The small groups especially, I think, incredibly valuable. We have got a lot of staff in the CCG really supported the vaccination programme and also supporting practices in their resilience journey. So a big thank you to them as well. So we're going to finish off with a poll, then we've got a quick video. So the closing poll, if we could have that, Jonathan. After today's events, do you feel you've had a chance to have your views heard? I've had lots of opportunity. Okay, still coming in. Most people are happy that they've been able to engage today. Okay, and after the discussions on GP access, how is your understanding of the pressures of GP practices? And again, it's very important to be honest. So do you feel like you've got a better understanding now, or you were already aware? Okay, he pretty much even split people living it versus those who've hopefully had an update. It would be really helpful to hear from members of the public and other stakeholders on how we can engage on some of those conversations outside of tonight. And after discussions on GP access, do you have a better understanding of the way practices are working and how to access them, e-consults, different professionals, etc., triage systems? Okay, that's great. So there's a few more questions. This kind of really relates to the event, and I know we've had big chats up at the Bootle Cricket Club and a number of other hotels, Park Street, etc. So would you prefer virtual or face to face? There's obviously advantages and disadvantages to both, and it tends to draw a slightly different audience. Some people have taken to the online world, but it's certainly good to mix it up, in my opinion. Okay, and what's the best time of day that suits you for this kind of event? Not many early morning risers. All right, and finally, would you recommend the big chat to a friend, colleague, or member of your family to come to? I'm probably a bit biased on that one. That's great. So we've got the video coming next, just a nice collage of different events throughout the last year and what's happened along the journey of being a CCG. I remember it back in 2011 when we were in PCT land and all the work to actually be authorised as a CCG at Formby Hall and what's gone on. So we've got a few snapshots over the last decade and just to let you know, of course, you can contact us and the communications team, which is on the last slide, should you want to engage further. We're very happy and it's essential to hear your voice. So thank you for joining us tonight.